Nick Majerison here. Welcome to Top Med Talk. We have EBPOM USA Wrong Surgery, Wrong Patient for you today. Recorded at the recent Evidence Based Perioperative Medicine, that's EBPOM USA conference, this piece in less than 15 minutes lays out the case for shared decision making so you can avoid carrying out surgery which is not right for either the surgeon or the patient. Use this to help build the case for shared decision-making at your institution by demonstrating that it hits the triple aim for populations by simultaneously delivering a better patient experience, better healthcare, and better cost. Presented by Mike Grocott, Professor of Anaesthesia and Critical Care Medicine at the University of Southampton. It's an excellent talk. Have a listen.
Top Med Talk. So for our next talk, we're going to be hearing from Professor Mike Grocott, who is a Professor of Anaesthesia and Critical Care from the University of Southampton in the United Kingdom. He's also an adjunct professor at Duke University Medical Center in North Carolina. He has a number of different leadership positions in the United Kingdom. He's an elected member of the Royal College of Anaesthetists, up to 15 minutes, on wrong patient or wrong surgery. Mike, welcome.
Thank you, Monty. So I am going to spend the next few minutes talking about and around this notion of shared decision-making. And I guess wrong patient, wrong surgery, it's clearly all about matching patients to surgery, but the notion that sometimes we get that wrong and there may be a bias towards action, as there are in many things, so a bias towards doing operations because that's what the system's set up to do. You present with a complaint, you go through a sequence of referrals, and the system just says at the end of it, with this complaint, you have that operation. And sometimes maybe we don't stop the train on that journey. And for sure, we probably don't involve the patients in that journey enough. So this is not what it's supposed to be about. It's an old joke. The operation was successful, but the patient died. But I guess in many ways it exemplifies the provider focus, the sort of paternalistic approach to medicine. And the shared decision-making is very much about a patient focus. And I borrowed this quote. This is one of your great theologians and philosophers. He managed to get himself the Presidential Medal of Freedom for being a great thinker in the United States. But a very familiar quote, which probably encapsulates how patients want to think about this. So understanding, having the courage to face what they might have to face in terms of surgery, having the serenity to accept that actually that might not be the right thing to do, and having the wisdom, and this is where we need to help them, where the shared decision-making piece comes in, having the wisdom to understand how to make that decision along the way. So in the background to this story is this notion of variation in healthcare, and I'll come on to in a moment the unwarranted, warranted variation. These are two examples from the Dartmouth Atlas, which very simply just plots procedure rates across the geography of the United States. There are similar initiatives in the United Kingdom. We have the NHS Atlas of Healthcare. And there are striking, often 5 or 10-fold variations in some procedures. The classic procedure that people used to talk about was elective tonsillectomy. The two examples here are back surgery and coronary artery bypass surgery. You can see that the variation is different. And one of the intriguing things is that a lot of that variation is driven not by demand but by supply. So when we think about variation in healthcare, there's this notion of warranted variation, which relates to how ill the patient is, what their particular medical needs are, underpinned by evidence-based medicine. So given that context, what's the right thing to do? On the other hand, we have unwarranted variation, which may be variation that's under use of healthcare because we've got ineffective healthcare, we're not effectively translating new innovations, we're not doing the things we ought to, patients can't get to us. But there's also very good evidence that there is some supply-sensitive care. So the amount of a particular procedure, for example, that's done is dependent, at least in part, on the number of people who want to do it. The number of cardiac surgeons around will dictate, to a degree, the number of cardiac surgical procedures, irrespective of the demand within a particular population. How do we put this in the context of perioperative medicine? Well, you heard, this is just a quote from that longer definition of perioperative care, and the really key element of it is from the moment of contemplation of surgery. So it's not about when the patient's listed, but it's actually even going further back down the journey to when they first start thinking about possibly having surgery. So they've got a diagnosis that could be treated with surgery, but may have a number of other possible treatments. And at that moment, we have a role. And therefore, it's very important that we get involved at that moment to get involved in that decision and help the patients decide. If we think about perioperative risk, there are fixed elements and there are modifiable elements. So how old you are, your gender, your genetics are something you can't do anything about. Your comorbidities, you may be able to modify to a degree, but many of the elements of those are largely fixed. And then we've got the modifiable behavioural elements, so the lifestyle elements, things like exercise, alcohol and smoking consumption. And they map onto different things that we can do as anaesthesiologists and perioperative physicians. So on one hand, on the lifestyle side, we can change behaviour. The modifiable factors we can modify, we can intervene. And we'll talk about that more during the rest of the weekend. To a degree, we can modify the comorbidities, and Sol touched on some of the dedicated clinics that can do that. But some of the fixed factors, all we can do is make sure we make the right decisions, or in fact make sure the patients make the right decisions, so inform them and help them on that journey. Which brings me to the notion of shared decision-making. Clinicians and patients working together using best clinical evidence, but based on the patient's informed preferences. And it alters what the medical role is from us telling patients what they need, you should have an operation, to us sharing information and seeking information about their life context. Does Granny have a christening coming up soon that she really wants to go to that really means she does not want to have a surgery this week or this month, for example? It's encapsulated with this quote about no decision about me without me. What we achieve through this is the avoidance of so-called wrong patient surgery. Now, this can be challenging. It can be challenging financially, but potentially, and certainly our experience in the UK system is that if you're in a bundled to capitated type system, it can be very beneficial, because the patients that choose not to have surgery, in general, we were the patients who, when you've had a conversation, are those that understand that they're at the greatest risk. And those are the same patients that are going to have more complications, they're going to present more of a burden to the health service. So it's a win-win. The patients are winning because they're not undergoing a procedure whereby the benefits will be outweighed by the harms. Nobody wants to do that. We wouldn't want to do that if we were the patient. And the institution's winning because they're actually removing one tail of the spectrum. And I've shown that the graphic there is this notion of a pyramid of cost, the fact that a large proportion of cost is concentrated in a small number of patients who have lots of complications, long stay. There's a significant chunk of activity that's actually very efficient financially, and a small chunk that shared decision-making can contribute to decreasing in size that is very inefficient financially. And so the funding incentives that we've talked about already this morning play into this in a large way. On one end of the spectrum, we've got fee-for-service, where the incentives clearly are for more activity. If you are paid to do something, you are likely to be inclined to do more of it. On the other hand, we have capitation, where the notion is that there's a fixed amount of money available to maintain the healthcare of a group of patients, usually in a geographical distribution. And somewhere in the middle, we have the various different types of bundled payments. And where you sit on this spectrum will in part dictate your views about shared decision-making. The last thing to say, and we've touched on this already, is it does require a rethink of the pathway to surgery. The anaesthesiologists in the room will, in most cases, I would guess, it may not be the case, things are changing, but in most cases, will encounter their patient a few days, maybe a couple of weeks before surgery. Whereas the patient and the surgeon have known that that surgery is going to take place several weeks before that. And the moment of contemplation may have even preceded that. And if we're going to achieve all these different things, prehabilitation, comorbidity management, but particularly shared decision-making, we need to be involved in the journey right at the very beginning in order to, if you're involved in the journey late, the patient will have a set understanding that they're having surgery. Meeting them some weeks after that and trying to explain that actually it might not be the right thing is a disaster from a communication perspective. If you're involved in the journey early, you can indulge in what in Southampton we refer to as staging the patient alongside, for cancer surgery, staging the tumour. So we can bring all that information together with the patient and then have a discussion about whether surgery is the right thing, or maybe an alternative treatment, or even no treatment might be the right thing, or watchful waiting might be the correct next course. So hopefully I've covered the bare bones there. I would put to you that wrong patient surgery is bad for patients, it's bad for healthcare, and it is bad economics, and therefore meets the triple aim completely. Shared decision-making gives us a way to minimise wrong patient surgery, And I'll just throw this at the end. When doctors are surveyed and patients are surveyed, most doctors are pretty convinced that they're already doing this. Most patients have a rather different understanding. So I'll leave that with you. Thank you very much.
Top Med Talk. Don't forget, of course, you can meet the Top Med Talk team. All you need to do is go to ebpom.org/meetings. Then you'll find some of the meetings that we will be in attendance at. And another way of keeping in touch with us, which we highly recommend, is the email list. Here's how you do it. Go to topmedtalk.com and sign up for regular email updates from us. We can then tell you when we are live on air via the website, because this talk that you've just heard, you may have heard it if you were listening to our live stream on topmedtalk.com. Occasionally there's even unique content that is streamed on the website. So you may be missing out if you're not part of our email mailing list. topmedtalk.com to sign up. That's topmedtalk.com.